Hi, everyone. I'm going to go ahead and get things rolling here. I'm Atul Grover from the Association of American Medical Colleges, and I want to thank the co-chairs of the Congressional Academic Medicine Caucus, Kathy Castor and Phil Rowe, for supporting the CAMC's efforts to really educate their colleagues on what we do, and particularly thanks to Elizabeth Brown of Ms. Castor's office for getting us the room, as always, and being a great supporter and great friend of academic medicine. We think we have a pretty timely briefing here today, given the events of the last several months, and particularly even discussions this week up here. I want to just sort of give you a brief overview of the nation's medical schools and teaching hospitals and what we do. We really thought about having this briefing just about medical education in general, but luckily my colleagues from across the country were able to join and talk about the opioid epidemic and what they're doing. And I'll just introduce them quickly. We're going to have each of them give some remarks, and then at the end we'll have time for questions and answers. I'm sure you'll have lots of questions about the work that's going on at their institutions and around the country. So immediately to my left is Terence Flotte, who is the Dean of the School of Medicine and Provost and Executive Deputy Chancellor of UMass Medical School. He's also on the LCME, which accredits medical schools. And so if you have questions about accreditation, I'm sure he can inform them as well. To his left is Dr. Bradley Allen, who is preparing for an LCME site visit, so I'm sure he can tell you about what that's like. And he's a Senior Associate Dean for Medical Student Education at Indiana University School of Medicine. He's also an Associate Professor in Infectious Disease, and he's been a Vice Chair in the Department of Medicine for Education as well. And our last panel speaker will be Dr. Alison Holmes, who's an Associate Professor of Pediatrics at the Dartmouth Institute and Geisel School of Medicine at Dartmouth. Geisel as in Dr. Seuss, if you weren't aware, best name of the medical school in the country, in my opinion. And last summer, Dr. Holmes actually received an award with her team from the AAMC for the Clinical Care Innovation Challenge because of the work that they've been doing on both opioid-exposed and neonatal abstinence syndrome-affected newborns. So that's a brief background of our guest today, and I'm sure you'll learn a lot from them. Again, we are an association that represents now 145 accredited MD granting institutions in the U.S. as well as affiliates in Canada, nearly 400 teaching hospitals and health systems, including most of the VA medical centers are also affiliated with medical schools. So there's a strong connection there, as well as representing academic societies and faculty. So at any given time, we've got about 300,000 physicians, physicians-to-be, or physicians in training in these institutions. And even though our health systems represent only 5% of all U.S. health systems, we perform about 50% of all the extramurally funded NIH research. Thank you very much for supporting that in the last go-around. We train about 3/4 of all residents and fellows in the nation, and we also have a big patient care footprint. We deliver somewhere between 20 and 25% of all the inpatient care and about 37% of all the inpatient charity care. We are always trying to lead on educational issues. I think part of what we wanted to get across to you today is that, it's difficult to just sort of look at what a school reports in terms of the name of a course and know exactly what they're spending time on. So I think you'll get a better sense of how that is changing. We've got the response to the opioid epidemic is still evolving. Just as medicine evolves, our education evolves because it's real time. And so what we were doing when I trained 20-some years ago was different. We had this on our radar screen, but I want to give you a sense of, I trained in San Francisco in the 90s. When I started my residency, we were dealing with an inner city population at San Francisco General Hospital that was dying of HIV. By the time I left my residency, the hospices were being emptied. It was the most amazing thing to have experienced, and academic medicine played an important role in that, and we're trying to play an important role here as well. You know what the scope of the problem is. I'm not going to belabor those details, but virtually all of our schools have integrated content in required and elective courses, and they do that in both their preclinical years, their early years in schools of medicine, before they actually hit the rounds with awards and active patients for the bulk of their training. We have to constantly evolve that curriculum. About 93% of schools planned or implemented changes in their curriculum in the last 5 years. They tailor that to accreditation requirements, but it's also responsive to what the needs of a local community are. And you'll hear some of those examples today from each of our three speakers. it's a long continuum. We're always trying to get more facts in there. And if you think about also the role of medical education in preparing physicians and other health professionals to take care of these types of problems that are emerging and that we're constantly learning about. Remember, you're going to do 4 years of medical school, 3, 4, 5, 7 years of graduate training, but then you've got to keep learning for that next 40 or 50 years. So how do we actually put continuing medical education in for the bulk of the people that are taking care of patients on a daily basis and teaching that next generation of physicians? When we know that whether you're talking about now having to learn about genomics and personalized medicine and all the new developments in medicine, we're struggling to get more and more into that curriculum and not just focused on the individual knowledge of that provider, but also to think about how you work in systems, how you work with other partners in public health and in other parts of the clinical care network. How do we teach interprofessional collaboration and also work on those very important bedside manner skills, which I know we don't do a perfect job of. And so I've actually given you examples within your packets of things that are going on all over the country. But you know, I look at these things that I did a little bit of in training. Duke students all now have to go to a 12-step or counseling type meeting. They have simulations for the first 2 years, and they're also involved in community outreach and service, all integrated around substance abuse. The other thing to think about is that we are not training enough physicians, period. And even though we've ramped up training of pain medicine physicians, also trying to do more of the addiction medicine physicians, we really are already running out of doctors in terms of getting to the places where they need to be and the total number. And just to give you an example, all the states in red are states that actually had fewer physicians, psychiatrists per capita in 2014 compared to 2009. So we're not making the kind of progress we need to make. Our recommendations have been continued funding for public health training programs that involves mental health, integrates what we're doing in behavioral health services, as well as trying to help train a few thousand more physicians per year by lifting the cap on Medicare's funding. And then consider the impact of various policies that you might consider on how they work at academic medical centers. Because if you've got hundreds of residents that are affected by the caps around treatment or substance abuse counseling for one attending physician or a handful of attending physicians, that impairs our ability to get that work out and to train more people appropriately. So with that, I am going to turn this over to Terry. And Clay, did you hide this for me? All the way down?
Just close it.
Close it? Yeah. Oh, sorry, thanks.
There we are. Thank you very much.
You're welcome.
Great. All right. Thank you very much, Dr. Grover. So I wanted to tell you the story about Massachusetts, and not just about UMass, although I will present some specific parts of the story that relate to our medical school, but to all of the medical schools in Massachusetts. And really, it is an example of where we were literally responding to a challenge from our governor, Charlie Baker, who is a very passionate, concerned advocate on this issue of the opioid crisis. You're all familiar with the scope of this crisis. This is data that came this month off the Governor's Opioid Task Force website in Massachusetts, which is run by the Department of Public Health, and it basically shows that we had more than a doubling of the deaths in Massachusetts from opioid overdoses that were not attributable to suicide. This has been an alarming problem. It just absolutely tearing apart many of our communities as it has affected predominantly young people. The way this slide works is on the top panel you see the normal, if you will, distribution of all deaths, the age at which people die. In the dark black are people over 65, which obviously make up the majority of overall deaths in Massachusetts. And the alarming epidemic in young adults, the 56% represents those that are 25 to 44, and 9%, which is an astounding number, that are under 25. So this crisis, this epidemic, and we do like to think of it as in those terms, it is a tragedy for many families throughout our state and many others around the country. So it was in this context, actually, that Governor Baker really presented us with a challenge. In late September, he called me personally and the deans of the other 3 medical schools in Massachusetts into his office, and much to my surprise, he, with his public health commissioner, Monica Barrow, sat and talked to us for 2.5 hours about his concern on this issue. And one of the things that he challenged us about is that physicians own part of this problem. The healthcare system owns part of this problem. It's quite clear in our communities, and there's evidence out there from some other communities, that many patients their entry point into opioid addiction are prescription opiates, some of which are prescribed for them and some of which are prescribed in excess and remain in homes around the community. And this just general oversupply of opiates, which we think anecdotally probably come from a very well-intentioned attempt to not undertreat pain, have contributed at least to the substrate, to the availability for susceptible individuals with genetic and social determinants that predispose them to addiction, predispose them to become addicted to a potentially lethal set of substances. So the governor called us in, expressed his challenge to us to get together as the 4 medical schools and come up with something to figure out what medical students should be taught. In other words, what the base competency that an MD should have. And so we assembled a group, and in about 6 weeks, culminating on November 9th, we, across the 4 medical schools, released a set of core competencies that described what we think every practicing physician should know. This is from that announcement. And one thing that's important, in addition to my colleagues, to the governor's, to his left, Karen Antman is the dean at BU, and Harris Berman, the dean at Tufts Medical School, and to his right, Monica Barrow, the public health commissioner. Right in between Dr. Barrow and myself is the head of the Massachusetts Medical Society, Dennis Dimitri, who represents all the practicing physicians in Massachusetts. So we, as the medical schools and all the practicing physicians, we're saying that we do own this problem. We do own part of this problem. We need to have people better trained to try to address this problem. Now, we came up with 10 core competencies, which we divide into 3 domains. And these are similar to others that have been published in in the literature and have evidence behind them. They basically break down into primary prevention, preventing prescription drug misuse by being more precise in understanding the extent of pain and evaluating options other than opiates, and when we do prescribe opiates, identifying those at risk for abuse and limiting amounts. Secondary prevention, learning how to treat substance use disorders in the early phase after diagnosis, and patients who are beginning into chronic pain management, understanding some of alternative ways to deal with chronic pain. And then tertiary prevention, which is really dealing with the more severe impacts of substance use disorders, such as being able to respond appropriately to save lives after an overdose, propagate the use of Narcan rescue, and then understanding substance use disorders as a chronic disease. Another one of the pillars of the Massachusetts program under the governor's leadership is to shift from having patients with substance use disorders treated as criminals to having them treated as patients, to move them from the criminal justice system into the medical system, but the medical system has to be prepared, medical and mental health system has to be prepared, and part of that is having providers recognize their own stigmas and bias. So at this point, we released these 10 competencies, and I have to say, we were patting ourselves on the back a little bit, had a nice write-up in the Boston Globe, which we shared with Atul, but the governor was not satisfied. He said to us, well, it's fine that you said what the standards are, what are you going to do about it? He wanted to see us moving forward in the current time and doing something so that the very next crop of students graduating would be able to be brought up to speed in these competencies. So this is a challenge. Medical schools are schools of universities. Universities function with shared governance with their faculty to develop curriculum. But this is an emergency and people are dying. So we did something, at least that was our response. And at the medical school, at UMass Medical School, we decided to create an immersive experience. So what envision now, we're into the last semester of a student who's done 3.5 years of medical school and is now just putting in his list of where he wants to match for his residency. How in the world can we get more opioid training? Well, we have an intensive time to train them right before they graduate, which is we call transition to internship. And we have devised an immersion to take out some time out of that final week. It's a week when we typically have them brush up on resuscitation skills and other core skills that you want people to be pretty up to speed on when they enter the hospital as an intern in July. So we're going to put all of our fourth-year medical students through this immersion. And I'll come back to it in a minute. We're also going to put our second years who are moving from the classroom to their first clerkship experiences through this. And we decided to take all of our nurse practitioner students. We also train nurse practitioners who are about to graduate, who are about to get their license credential. And we've worked out how to address at least somewhat each of the 10 competencies in an interprofessional experience. And the core of it is there are going to be 4 very intense scenarios with standardized patients, patient actors. This is a format we use a lot now in medical education. They can simulate physical findings, but most importantly, the history and answers and interactions, interpersonal interactions. One of those also includes mannequin-based simulation for resuscitation after an opioid overdose. Well, that is the third bullet here. We also are going to have group sessions with substance use disorder patients in recovery and reflective writing. And this whole unit here that they're going to have in that last week is also going to provide us an assessment. So we're going to assess where they are. We're going to give them immediate feedback so they have tools going into the internship. But that assessment will give us information about where the gaps have been in the first 3 years, 3.5 or 3 3/4 years of medical school, and enable us to go back and add where we need to add to bring everyone up to speed based on this competency model. This, we think, is not just working harder at teaching about opioids, but it's working smarter. So this is what it looks like. We were doing a run-through to try to work out some of the kinks with this. You see 2 of our medical students here on the upper left with one of our faculty, Kavita Babu, with actually a former colleague of some of yours, Marty Meehan, former congressman who is now president of the University of Massachusetts, who was, his family's been affected by this, and he was very affected when he saw them working through, personally affected when he saw the students working through this simulated scenario with the patient actors on the right side. The woman there was portraying someone who had just been successfully resuscitated from a life-threatening overdose with her husband, and they are quite good at making people very uncomfortable in terms of what the dynamics are around that situation. But the students learn how to interact with patients in these situations, and also more concretely how to prescribe Narcan rescue, nasal Narcan to keep at home. Last slide, this is just a first step. This is what we've done on the fly in the current year. We're working to use our curriculum mapping to map what the gaps are that we're going to identify in the assessment part of this, that we're calling an OSTI, the Opioid Safe Prescribing Training Immersion. We're working right now to integrate interns and residents. Some of them will participate in some of these OSTIs, and we're working with the GME committee to put some of these into some of the other residencies. I have to say, our residency in family medicine and our residency in psychiatry get great training in many aspects of this, but one of the other things, the whole point about saying every MD needs these things is we've recognized that MDs across the whole spectrum, general internists, surgeons, surgical specialists, if you have a DEA license and you can prescribe opiates, you need to have this set of information. And now on the next phase in our working group that we're meeting, with the public health and the governor's task force as we keep going, we now have all the dental schools at the table, several other nursing schools and pharmacy schools. This needs to get to the whole team. I think Atul mentioned this, we have a whole spectrum. We're also working with practicing docs, but we're trying to start where we have the most control and get the most intense experience so that at least we're not putting out any new physicians who have big gaps in their training. So with that, I think I will end and turn it over to Brad Allen, who's will present next from Indiana University.
Okay, there we go. We'll be there for a second. There.
Great. Just another talent that they have here in terms of their audiovisual techniques. So thanks for inviting me to be a part of this today. And I'd like to tell you another story of, again, a way that we don't always anticipate about the secondary effects of the opiate epidemic. So Austin, Indiana, small town in southern Indiana, 4,000 people, pretty homogeneous population, 20% living below the poverty line. Jobs have gone away, 9% unemployment, and about 2 primary care providers in that area. So relatively medically underserved. So multiple cases of HIV were detected in that area, and rapid recognition and then delving into what the source of those cases were quickly revealed that it was due to injected use of Opana, which is a long-acting oxymorphone derivative, which is crushed, solubilized, and then injected for a high. This was being used by a large circle of individuals in that area. And to date, as of late October's data roll-up, 181 new cases of HIV were identified in this circle of users in this quiet small town in southern Indiana. The age was about 33, predominantly non-Hispanic white, not the typical demographics we would typically associate with an HIV outbreak. 92% of the individuals were also infected with hepatitis C because of their needle-sharing activities. Once cases were detected, they went out and talked to and interviewed potential contacts of these individuals, and the findings of new HIV diagnoses in those first 500 people was almost 40%. Amazing positive results here. There's still people that we're going after to try and do the testing, so there certainly can be more cases than what we see there. So as we go through what I just talked about a little bit, the first case was diagnosed late in 2014. Within a couple of months, the cluster was identified. A local awareness and command center was set up. HIV testing was made widely available so that we could get people to come in and make the diagnosis as quick as possible. Federal support was provided through the CDC. A public health emergency was declared within the state to react to this outbreak. and a local HIV clinic was opened because there was not HIV care in that area of southern Indiana at that time. A needle and syringe exchange program was started, which was new for the state of Indiana, in the spring of 2015 in response to this epidemic, initially on a county-wide basis, but now is rolled out to most of the counties across the state of Indiana. And then late in the summer of 2015, we actually started to implement the use of pre-exposure prophylaxis, or PrEP, to protect those people who are at risk of acquiring HIV because of their activities and people that they were exposed to. You see that Scott County, where this happened, is in southeastern Indiana near the Ohio River and Kentucky border. So to date, the needle exchange has been very effective. Over 28,000 needle exchanges have been documented at this point, and thankfully we're seeing the curve bend in terms of new cases that are being discovered in southern Indiana. I want to highlight the fact that this work was aided by a couple of members of our infectious diseases division, and more importantly, was aided and heavily involved one of our trainees who was an ID fellow, who was a native Indiana person who went through training at our medical school and then our fellowship program, and had the skills to be able to go out and help implement these programs to make a difference in southern Indiana in this HIV outbreak. So again, in summary, the HIV outbreak all could be traced back to one case of HIV coming into this circle of users of opiates, and all of the cases so far have had exactly the same strain that has been spread from person to person to person from the needle sharing process. What did we need to do to address this urgent epidemic of HIV? We needed to raise awareness in the community and amongst the providers of how widespread this opiate abuse was in these even rural areas, to help them remember and how to integrate screening for bloodborne illnesses that went along these people that had developed dependency on opiate drugs. And then how do we help prevent then secondary cases of HIV and Hep C through sexual transmission from those who interact with those who had been infected through their IV drug use. So things that have been going on for actually quite some time in our curriculum through IU School of Medicine, that was shared earlier, have acted at the undergraduate medical education level for medical students. We've had programs for quite some time in our graduate medical education, that is with resident physicians. But we've also started to expand to interprofessional education, which was talked about, to spread into those other areas that help make up the teams that we need to address issues of pain management, to address issues in terms of recognition and treatment of opiate abuse, as well as for HIV care and screening. So the outreach also covered physicians across our state to help them recognize that this was a problem, that it happened in southern Indiana, but it could pop up any place within the state. In 2011, we were able to get a grant to the state, a SAMHSA grant, that helped us develop this ESPERT program, which I'll talk a little more about. We also had to react to this HIV outbreak, and again, we need to be proactive to help people recognize anything that looks like one of these impending outbreaks in other parts of our state. So our GME efforts were the things that were probably most fleeced out and developed early, and it's required training within our programs that cover most of our frontline caregivers, that is internal medicine, pediatrics, family medicine, emergency medicine, and psychiatry. They were all trained in ESPERT, which stands for Screening, Brief Intervention, and Referral to Treatment. That is, in a short clinical encounter, to have a conversation with a patient, to detect if they have any issues with substance abuse, to do a brief intervention to start that conversation that this is something that they need to address, and then how to refer them to the proper individuals that can help them get treatment for those issues. This involves topics of motivational interviewing skills, which help lead them to their own revelation that they have an issue that they need to take care of. And this involves early training and communication skills that help our young physicians be able to have that conversation effectively with the patient and draw that closeness and that association in the patient-physician relationship that will allow that information to come out. And then also to gain appreciation for integrated methods of pain control that don't involve necessarily use of opiate medications. Our undergraduate medical education involves over 12 hours of lectures and small group activities just within the first 2 years of their 4-year program that, again, deal with these alternate methods of treatment with the expert training, even to medical students, and then awareness of the importance of screening, treatment, and communication about substance abuse. We also start to introduce them into the medical legal aspects of what's required for prescribing opiates. In Indiana, we have the INSPECT program, which allows us to keep track of patients' prescriptions wherever they happen around the state so that we can make sure that there's not doctor shopping going on that might be a problem. In our later years of the medical school curriculum, we again introduce intoxications, including opiates, to our sub-internships. As was mentioned earlier, those students who are just about to head out into the residency training to recognize the issues that come with heroin abuse, withdrawal symptoms, and again, helping them remember ways to treat pain in people who may have had issues with substance abuse in the past. This is not an easy task at Indiana University School of Medicine. We're the largest medical school now in the state, in the nation rather, and we have 9 campuses that are around the state of Indiana, some of which are more urban located, some are in smaller communities. So it's sort of a microcosm of what's needed around the country that we have to think about what resources are available in that location where we're delivering the education product. And it may not look the same in all of those sites, but we want the end result to be the same. We have a new curriculum that's starting in August, and ways that we are further integrating the topic of opiate use and abuse have come from a grant that we received from the American Medical Association, an Accelerating Change in Education grant that has allowed us to develop an electronic teaching medical record to give students an early exposure to the electronic medical record that we're all expected to use these days, how that can be a crutch to help us remember to do certain things in terms of our prescribing of medications, but also awareness of what the medical record can't do in terms of helping us and threats that it might provide in terms of misinformation that could be propagated in the medical record. We've also, again, as was mentioned earlier, looked for opportunities to integrate our education along with other disciplines that we'll be working with in a multidisciplinary delivery of care as they go out into their residencies and practice. So including pharmacists in the roles in our Foundations of Clinical Practice course. Again, we've developed, or in the process of developing, additional modules which will include training side by side between medical students, nurses, social workers, physician's assistants, dentists, all those things, so we can all learn at the same time to realize what those different disciplines can do and what they can't do in terms of forming a teamwork that can deliver what we need to do for pain management and treatment of addictions. As mentioned, interprofessional education can include all of those different disciplines that are listed at the bottom of my slide, and I think these materials are handed to you and made available. We recently put in another grant to SAMHSA to integrate this expert training to help us appreciate and screen opiate abuse across all different disciplines that are present and active in a current multidisciplinary care team. We also need to attend to the needs of our practicing healthcare providers out in the community. So the IU School of Medicine Continuing Medical Education Group has developed things on the fly based on the needs and requests of physicians across the state. Obviously, we've recently developed new modules to look at HIV screening and treatment. Not that all providers are going to be doing that. We're still going to refer them generally to an ID specialist, but they need to have awareness of how to screen, how to refer, and things like that. Additional ongoing symposia on new and alternative methods to pain control that don't include opiate medications, raising awareness of what the expectations are that come from federal and state mandates in terms of oversight of opiate use and prescribing, and then again, always coming back to making people aware that there are ways to control pain that don't include opiates, and how to have those conversations with patients that do have real problems with chronic pain that need to be controlled so that we can help them get the relief that they need, but to do that in a safe way. So my summary of the educational needs that I think we need across the country, because we need to realize that all areas of the country are affected, both rural and urban, and sometimes there's these very, very serious secondary threats that come with the opiate epidemic. We need to address pain management, I think, more effectively at all levels, to start in medical school, to continue that through the residency training, and then continue to offer updated models of care to our physicians and all healthcare providers that are involved in addressing chronic pain and addressing opiate abuse and recovery programs across the country. So at that point, I will stop.
Thank you for inviting me to speak today. So while HIV is one other downstream effect of the opioid epidemic, the babies, newborns who are opioid exposed in utero are yet another downstream effect. So I'm going to talk about how to improve our care for families. And as Dr. Grover mentioned, this was one of the winners of the AAMC Quality Innovation Award last year. So we're going to talk about rooming in to treat neonatal abstinence syndrome. So neonatal abstinence syndrome is a syndrome of drug withdrawal in neonates who are exposed to opioids that their mothers are taking while they're pregnant. There's a whole spectrum of signs and symptoms that I will not get into, but we diagnose neonatal abstinence syndrome by history, by toxicology screens. We care for the babies by trying to optimize their environment of care by having them cared for in a very calm environment where they're held frequently and fed on demand. And in more extreme cases, we use medication for babies who have withdrawal symptoms that can't be controlled with the environment alone. The type of medication that the mother is taking does not have a huge effect on whether or not the baby withdraws, but it's important for mothers who are abusing opioids at the time that they become pregnant to get into a treatment program and to be maintained on a long-acting opioid like methadone or buprenorphine. I find that many people don't totally understand that, and that's an important thing to understand. They should come off the short-acting opioids, which can cause them to have preterm births or stillbirths or babies who potentially have some degree of brain damage when they're born, and to be on a longer-acting opioid through the pregnancy. So we tried to set this up as a triple aim type of project where we tried to improve something that was important in our population and improve the experience of care for the families, as well as lower the cost of care. So this shows NAS, as we call it, in New Hampshire and Vermont, and up at top it states that back in 2012, when we started our project, we had about almost 2% of our babies born with the syndrome versus about 0.6% nationally. The syndrome is withdrawal that's severe enough to require medication treatment. So just being opioid exposed does not mean you had the syndrome. So we had 2% that were severe enough that they needed to stay in the hospital. And nationally, the hospitalization is about a month long to come off of medications after when they're withdrawing. The graph here shows where we started in 2000. We were about 2 births per 1,000 with the syndrome, but by 2012 we were up at 19 births with the syndrome. We just finished our 2015 data, where we have 10% of our newborns at the Children's Hospital at Dartmouth that are now opioid exposed in utero. So 1 in 10 of our newborns has been exposed to opioid medications in utero. We are a referral center, so our rates are a little bit higher, but even at our community hospitals, we are in the range of about 5 to 8% of our newborns in our states being exposed to opioids in utero. So this article came out in May of last year in the New England Journal about the increasing incidence of neonatal abstinence syndrome, and particularly about United States neonatal intensive care unit beds, and basically that 4% of these beds are now occupied by babies that have NAS. And the length of stay I put in the corner is anywhere from 24 to 32 days for these babies after they're born. So we did a quality improvement project, and this is just an overall diagram of the different cycles that we did. I give a 45-minute version of this talk as well, so I'm not going to tell you about these today. But we did many different interventions and measured our outcomes as we were going. I do want to tell you a little bit about one of the early cycles, our family interviews, because I think it was key that we interviewed and got perspectives of the families that we were caring for before we did any of our further interventions. Because our parents told us some really important things. They told us that they wanted to know about NAS and to be prepared for the birth of their child. They said things like this, and these are all direct quotes from an interviewing project that we did. They said, "I wish I had known a lot more about NAS before I gave birth. I didn't think the consequences would affect the baby so much." They want to be partners with us in the care team for their child. They said things like, "I know my baby more than anybody else does." So they have to rely on that to help them out with scoring, which is a way that we assess the babies, and knowing what she's going through. And interactions with staff, with us. I'm a recovering heroin addict. I think overcoming something like that and then feeling like you're judged because of it, you end up building resentment towards people. So we did many other changes in our clinical care, including a rooming-in only environment. So we actually removed the neonatal ICU from our care so that families stay together with their babies, first on a mother-baby unit, and then on our inpatient pediatrics unit, unless the baby is ill enough for some other reason, like prematurity, to need to go to neonatal intensive care. But for most of our babies, they can stay with their families the whole time. So in terms of our level of pharmacotherapy, the babies receiving morphine, so those that have symptoms severe enough to require medication, we went from a baseline rate on the left of 46% of our babies getting treated with medication, which is just about where most places are nationally, down to 27%, so more like 1 in 4 by the end of our 2 years of intervention. Looking at our last 6 months of data, we're actually down to 20% because we've really optimized the environment of care and the support of the family in being able to take care of their baby with our help. This is a graph of hospital costs over time. So each dot represents a baby that was treated with medication over a 3-year period. And so we started out with mean costs of about $20,000 for a treated baby, and we dropped down to $8,700 by the end of our study. This data is going to be published in the Journal of Pediatrics over the next few months. On the bottom right, you can see that when we did a cost analysis for all of our exposed infants, so any opioid-exposed baby, the 1 in 10 that we have now, the cost of the population that's been exposed to opioids in utero has dropped from $11,000 per baby to just about $5,300. So what does this mean? There are many centers with a length of stay of a month or more. We dropped our length of stay from 18 to 12 days, so we're much below the national average. So the hospital course could be significantly shortened. And if the model is adopted widely, there are potential cost savings. And of course, what I tried to show you from some of our family interviews, a tremendously positive impact on our families that we care for. So looking at kind of national data and rates, potentially in terms of charges and costs if this model were adopted widely, be a savings of about 1.8 billion in charges or 600 million in hospital costs. So our students were very much involved in this project and in clinical care. In addition to quality improvement work, I also co-direct the required third-year course that every single one of our Geisel medical students takes in pediatrics. They're all with my co-director and I practicing pediatrics for 8 weeks. They all come through the newborn nursery, and pretty much every single student takes care of a baby that has opioid exposure or neonatal abstinence syndrome during their third-year clerkship course. In addition, we have a fourth-year course in quality improvement at our medical school, and I lead one of the small groups every February for that course. So 2 years ago, we had a group of 6 students who did some of the data analysis for the project that I just showed you as their senior year coursework in quality improvement. I also had a research year student, someone who spent an extra year, and she led the family interviewing project as part of that project. So she will actually have, I believe, 2 manuscripts from this project from her research year. And we have questions. Thanks.
So we'll start with questions that any of you have, and if there's a particular doctor up here you want to direct them to, just let us know, but otherwise, we'll see who can answer them best. Yes, sir.
Dr. Flotte. And, oh, okay, people can hear me now. All right, perfect. My question, Dr. Flotte, is I was just going through my notes here, and I noticed that one of the propositions you suggest for the OSTI and the UMMS is mapping gaps in the OSTI. Could you give us perhaps maybe a couple of implications or what those gaps might entail or what they might potentially be?
Yeah, thank you very much. Yeah, so what I was referring to is the fact that we're going to be including in the way we have it laid out. There's going to be an assessment as the student at the end of the 4th year has this experience, and then they'll get additional training that day, additional practice if they need that for the procedural components of it, in order to meet the 10 competency areas. But if there are areas where the students on the pre-testing, if you will, with their current state, are consistently lacking, then we're going to plan to put that into various courses. We do have training, we do have fundamental education in the pharmacology course about what opiates are, what the opiate receptors are, what antagonists and so forth, but we may not have enough in there about, for instance, about medication-assisted therapy with Suboxone and so that might be something where we might find, as an example, that we need some more help. What we're guessing is that of the 10 competencies we've just agreed on, that we'll do better in some than in others, and then that'll guide us for the coming year. So we're going to try to get as much as we can on that done this summer so that we'll incorporate it in the very next year.
Other questions? Yes, sir, in the back.
Yeah, one question for Dr. Allen. I'm pleased saves me shouting. For Dr. Allen, I was pleased to see your discussion of SBIRT and INSPECT, which sounds like Indiana's prescription drug monitoring program. Can you explain or provide a little more detail on where you teach SBIRT to be implemented, I assume in primary care, and is INSPECT kind of integrated into that screening process?
Yes, great question. So over time, we started our SBIRT treatment primarily in our residency training, or GME training, excuse me for my voice right now. But over time now, we've integrated it into our medical school training and are in the process of hoping to get funding to allow us to do that through the other professional schools. Most of that does occur in an ambulatory setting, where they go through modules to learn how to do it. They spend time with either primary care providers or with some of our behavioral health providers to go through either standardized patients or real time with patients to practice those skills to make sure that they can do it adequately and are able to solicit the information from the patient and give back information in a way that's felt to be productive. As part of that, too, in the ambulatory experience, they have the opportunity in most of our clinical settings to, when a patient is on an opiate medication, to go through the process, like all providers do, of logging into the InSpec system, looking into the patient's prescribing history to make sure that they are using the medications, refilling the medications as they're prescribed. So I think we need to, raise awareness, which again is different, in each location. And every state has a little bit different program to supervise prescriptions of these agents. And so there needs to be some customization, I think, depending on what locality that you're in. So thank you.
I don't know, Terry, if you have any other thoughts about the accreditation standpoint.
Yeah, so I think, accreditation is obviously, if you look at it over all of medical education, is a very complex topic. This type of very specific competency, you could see in some ways more readily being highly specified within the milestones for each ACGME accredited residency. So if again, I know some people in the audience know a lot about this and some people don't, but every specialty, whether you're in pediatrics, family medicine, psychiatry, defines what at each level of training one needs to master in order to move to the next level. That is a new concept, the competency-based milestones, but that's what they're called, milestones. And certain things are specified that each physician at each level in that specialty has to be able to do. And if you don't pass through it, you don't finish your residency satisfactorily, then you don't get to sit for the boards for that specialty. So that part, in a way, within each specialty, there's a mechanism much easier to be very specific. And although, the point there is that every specialty has to decide to do it, and they operate fairly independently of each other. At the medical schools, our basic concept is that we want to train the undifferentiated physician who is then competent to move into any field of residency, any field of graduate medical education. That's actually one of the standards that the accreditation body, the LCME, has out there, and it's a good summary one because it encompasses a lot of things that change over time. The LCME tends to not want to keep adding things into specified content, although it is one mechanism that has been used in the past. There are specific topics that are identified within the 12 standards of the LCME for accredited U.S. and Canadian medical schools that talk about particular areas. They talk about them pretty generally, but right now the words opioid prescribing are not among those. So that is a process that could come to bear, but it would still require, well, first of all, it would require a lot of cooperation to get it in there, and second of all, it would then require individuals in the medical schools, individuals like Dr. Allen, who's in charge of all the education at his institution, or like Dr. Holmes, who's in charge of educating students within pediatrics in her institution. They would have to be able to figure out how to meet that requirement. So I think it's much better for schools right now to work rapidly to get up to speed on what the agreed upon standards are for the undifferentiated doc. And of course, the residencies can dive right into this, and I'm sure there are many. I'm not intimately familiar with the milestones, but I know that there are some very rigorous ones in the basic residency of psychiatry, and there are fellowships even beyond residency for people who are at that super specialization of dealing with addiction medicine. I guess one of the points, though, is that we need more training at the more undifferentiated level. We can't say that this is a problem only for addiction medicine specialists anymore. We need a better level of competency, we feel, for general surgeons, for general internists, general pediatricians, and down the line, as well as for specialists in subspecialty areas, because they can all prescribe opiates and need to be able to do that responsibly.
Is there another question over here? Yes, ma'am.
This question is for Dr. Holmes. Does rooming involve being released to go home together, or does rooming in involve the mother and the baby going home together, or staying at the hospital and being treated together?
So it depends. Our rooming in refers to in the hospital to being treated together. And I should explain with some background that a significant majority of our mothers are well into recovery by the time they deliver a baby, because pregnancy is long and it's often a very motivating factor to get into a treatment program. And also, treatment programs are more accessible to women when they're pregnant because they're seen as more of an emergency because there's more than one person involved in the treatment. So many of our mothers are well into recovery and are very motivated to take care of our babies. All of our cases, or almost all of them, involve some degree of state child protection investigation. Most of our cases, the families do well and the babies do go home with the families. In a minority, around 10 or 15% is where we are at our center. The family is not well enough into recovery to be able to parent the child. And so there's a whole spectrum of what we see in that in terms of going home. Sometimes there's kind of an in-between within family placement. So let's say a healthy grandmother and the mother's somewhat into recovery and the mother can live with, say, her mother or the father, the baby's mother, and the baby and have some supervision. And sometimes some of our parents are unfortunately still very actively abusing and can't take care of a baby. And so some of our babies do go into foster care placement. We do like, as best we can, to identify the who's going to be at home early in the course, and especially the foster families, so then they can come in and room in with the baby and learn how to take care of them when they go home, because they're not always the easiest babies to take care of.
Well, I want to be respectful of your time, and I appreciate your being here. And please join me in thanking the panel. And I think if you have burning questions that you want to come up and approach them about, hopefully they'll have a little bit of flexibility. But thank you for joining us. That was great. Thank you.
Thank you.
Big help.
It was great topic.